Unless change making becomes an intrinsic part of everyone's job every day in all parts of the system. So this is one of the things that motivates some of us to do what we do. Now the question is, what is leadership? I mean, leadership is an attitude. It is not a position. So leadership is not CEO. Leadership is not managing director. Leadership is not head of department. Leadership is an attitude. Leadership is also a process, and in this process, the individual learns or is able to influence a group of individuals to achieve a common goal or an objective. So leadership is also influence, and leadership is a function of a leader, the followers, and the situation in striving to achieve a common purpose or a goal. So if leadership is influence, the question then is, how do we influence? How do we influence? I mean, so we influence by two ways. You influence by the heart and then by the mind. Influencing by the heart is 95%. And in influencing by the heart, you will have to build will. And you are building the will of your stakeholders. You are communicating effectively. And you are applying all the influencing styles that you know. In influencing by the mind, that is only 5% of the business. And in influencing by the mind, some of the things you can use to influence by the mind is data analysis and then your flow analysis. In data analysis, it talks about measurement and measuring variation. Variation is just differences that occur maybe between your standard and then between your standard and the practice. And then your planned measurement. Measurement is what the data you are collecting daily and what is informing you as far as your system performance is concerned. The flow analysis is just an analysis of your patient's journey. And some of the things you can use for that is your process map. So I mean, for us in clinical care, our mindset is different. Our mindset is mostly about evidence-based practice. We are interested in measurement, we are interested in metrics, and we are also interested in how we are able to use our clinical systems to improve. And we want to ensure that there is a reduction in variation. Variation is differences. So if I treat a patient with a particular medication today, I expect that with the same medication, I will get a similar or same outcome tomorrow. But once there become a difference in outcomes, if I use the same medication, then I begin to worry. And I would like to ensure that whatever variation that exists is reduced. And for us as clinicians, we are also interested in ensuring that we are redesigning our patient pathways or their process maps as much as possible. And as far as the heart is concerned, in engaging the heart or dealing with the heart or influencing as far as the heart is concerned, I mean, you will have to be imaginative. You will have to engage your imaginative skills. You will also have to engage and relate. You will have to facilitate participation and encourage movement and mobility so that you are able to call your team to action. I mean, this is key. So people should be able to do it without even finding a reason for, but they become convinced by the heart that whatever we are calling them to do is the right thing to do. So, I mean, who do we influence? So we have what we call strong ties and weak ties. And this is what Helen Bevan says. He says that in health and care, most change happens through strong ties. We are influenced to change by people like us with the same background, interests, and experiences as us. So change is spread peer to peer. But he adds a caveat. He says that yet the best opportunities for breakthrough, radical change, comes when we also operate through weak ties, connecting with people who aren't in our usual peer group, who bring fresh ideas influences and perspectives. So that is what Helen says. So I mean, we can influence across various levels, and this is very important. So it helps us to know our spheres of influence and what we can do and not do as far as influencing and getting people to do what we want them to do as leaders is concerned. So I mean, your strong ties are the people you know. That's the people who are in your phone book and your phone contacts. They are your colleagues and friends at work. Like some of us on the call, we interact with them daily and regularly, and we have conversations with them. And we all have the same network, and there is some level of high maintenance and relationship. But for weak ties, the relationships are weak. I mean, the weak ties, the people we have weak ties with, some of these people are our Twitter followers or our friends on Facebook or our friends on LinkedIn. Some of them, we haven't even met them before, but by way of some level of attraction, and by way of some level of attraction or some level of weak relationship, I mean, we have come to know one another, or we don't even know one another. So these are some of the groups that we can influence as far as our leadership and our influencing is concerned. So if leadership is influence, then who do you influence? So these are the people. I mean, for leadership, there are various perspectives of leadership. We have the systems approach to leadership and what we call the old style or the old school approach. So I mean, as a leader, you would have to be context, um, you would have to have the perspective of context other than being detailed. So when you are when you have a context perspective and you are thinking the systems approach, you are somebody who appreciates details in relation to the wider environment and settings. The old style of this is that these people are overly focused on details and they largely neglect the contextual factors. So with a system approach, we appreciate the details and we appreciate its relationship with the environment and the contextual factors. You are also mindful of cause effect as opposed to symptoms. You are able to recognize critical and fundamental cause and effect relationships. If I do this, it would lead to this. If I do this, this is the likely cause or this is the likely consequence. However, the old school approach, we become primarily concentrated on unconnected signs rather than root causes. The other is that we are multidimensional as opposed to one-dimensional. And with the systems approach in multidimensionality, you understand interaction, interdependencies, and interrelationships of multiple factors. I mean, if you work in obstetrics, and you are in the ward, you are mindful of what is happening in the obstetrics emergency because whatever you will receive in the ward is likely to come from the obstetrics emergency. So you are mindful of these interdependencies and interrelationships. The old school approach is about complexity, and complexity is essentially reduced to simplistic proportion. And you are also dynamic as opposed to static. And the one who is dynamic in the systems approach is able to adopt a long time perspective. But the old school person becomes fixated. He says, as for me, that is how I am. That is how God created me. And the proactive as opposed to reactive in the systems approach, that person is supportive of attitudes for taking charge and managing change in a timely manner, as opposed to an undecisive person who is laissez-faire, whose attitude is laissez-faire as far as the way of doing things is concerned. This is what Charles Darwin says. He says that the species that will survive the future, they are not the most intelligent, nor the strongest, but those who are capable of adapting to change. And Machiavelli also says that there is nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. For the reformer has enemies in all those who profit by the old order, and only lukewarm defenders in all those who profit by the new. So as leaders, leaders shake the foundations of their institutions and they shake the status quo. And whoever is going to shake the status quo and cause change, you will have enemies because you are going to create a lot of discomfort for people who are benefiting from the old order. So, change can be difficult, and change can be difficult because of the issues of power and the dynamics of power in our setting or in our environment. Change can be difficult because of how hierarchical our environment might be or our environment is. And the tradition, people have become fixated, and this is how we do it here. And when did you come? And this is how it has been done. People have become fixated with their old ways of doing things. So, it will make any change that shakes their status quo will be difficult and it will be resisted. And change is difficult because of how we are designed, silos, and we are thinking individuals other than thinking of teams, other than thinking of interrelationships and how we are able to work together. So in all of this, it makes change difficult, and change is difficult or can be difficult because of how dysfunctional our systems are and our professionalism and how strictly professional we become sometimes, overly strictly professional. This is not my work. This is not my work. This work is for this person. So because of all of this and many others that most of you know, it makes change very difficult. So to achieve change and to ensure that change happens, there are a few things we have to do. And the first thing is that it cannot be work as usual. That is the first thing we have to note. And in order for it not to be work as usual, we should ensure that we have to have a new way of thinking. And this new way of thinking is saying that this new way of thinking is saying that we need different ways to solve our problems. It cannot be the old way, using the old tricks all the time. Times have changed, so we have to use we need different ways of solving our problems. And then it is also about having a change culture. And a change culture is a change language and the way we act and the way we teach and the way we do things. That is also very key, that we are mindful of change and we are happy and we are always ready to embrace change. Because as we have seen in the quotes that I have shown you, we cannot be static. And there is also the need for active changes. And active changes has to do with actively and deliberately adopting new ways of solving our problems and new ways of doing things. So these are very fundamental. Now, as leaders or as clinical leaders, there are a few theories and concepts that we have to know. One is that we should know that what we have as input, and this is from the Donabedian, inputs are the things we have, the resources we have. If we have our inputs, if we have our processes, and our processes are the way services are delivered. A process, for instance, can be an injection process, how we give an injection. A process, for instance, can be the way we take our temperature. A process, for instance, can be the way we do vaginal examination. So your inputs would be the human being or the human resource, the gloves, etc., that you would require. So we should be mindful that your inputs and your processes will give you an outcome, whether the patient is well or the patient is unwell, whether the patient dies or the patient recovers. These are some of the outcomes. Another thing we should be mindful of as leaders is what we call the quality dimension. And these are from Institute of Medicine. Is our care safe? And safety is asking whether we protect ourselves as members of staff, whether we protect our patients and our relatives from harm. The service we deliver, is it timely? And timeliness is asking, do we ensure that people receive care when they need it? Is it equitable? Do we provide care devoid of all forms of discrimination? And is it efficient? Do we ensure that the care we provide is done without wastage of the available resources? And is the care we provide effective? Do we provide the right care every time, guided by the available evidence? And is the care we provide, is there any integrity in the care we provide? Do we provide care devoid of corruption and collusion? And is the care we provide integrated? Do we provide care that is a one-stop shop? I mean, sometimes I have seen patients carry ice chests roaming from one hospital blood bank to the other. One time, a colleague called me at 12 midnight, roaming with his blood request form, asking for blood from one hospital to the other. Another is the corruption that have bedeviled the care we provide. We take money from patients, we don't give them receipts. And sometimes we don't even provide the services we have taken the money for. And the other is the people-centered care. Do we treat people with all the respect that is needed? Do we treat them in dignity and with compassion? So these are a few theories and concepts that we need to be guided by as burden leaders or as leaders as far as the provision of quality healthcare is concerned. I mean, the thing is, you cannot do it alone. One definition of leadership is about aligning people so that you are able to attain the outcome. Now, the question is, how do you mobilize or how do you organize your colleagues so that you are able to drive the change that you would want to be driving? I mean, one of the first steps has to do with your strategy. And your strategy is your mind. It is the what. What are you bringing them together to come and do? What do you want them to come and do? And if they come together, what exactly do you want? What do you want to attain in bringing them together? The other is the narrative and the why. Why are you bringing them together? That is touching their hearts. How are you able to touch their hearts so that together, when you pull them together, you have a shared understanding. And Peter Senge calls this a shared vision. That is the destination. At the end of the day, there will have to be a convergence of a shared understanding and a shared vision. We should all be driving and moving towards the same destination. That, hey, we want to ensure a zero maternal mortality. We want to ensure a zero third degree perineal tear in our setting. We want to ensure a zero mortality due to hemorrhage. We want to ensure a zero mortality due to sickle cell disease. I mean, so that becomes the shared vision, the shared understanding. So our ability to ensure effective mobilization and pulling our people together through strategizing and through winning them at their mind and sharing with them what we want and sharing with them why it is necessary that we are mobilized and why it is necessary that we work together, because the vision and the understanding becomes compelling enough. The thing is that there will also have to be a movement, that we will have to change what message we share. I mean, we will have to move from the deficit, what we call the deficit based messaging, to an asset-based messaging. The deficit-based messaging is always asking what is wrong. But I mean, we should move from asking what is wrong to what is right that we can build on. We should move from solving problems to exploiting existing assets and resources in our environment. We should move away from identifying development and improvement needs, identifying what we call positive deviance in our system, positive variation in our system. And we should move away from gaps and deficiencies that have to be filled towards a point where we are able to amplify what works. Let us share what works. Hey guys, if you do a vaginal examination this way, you are able to reduce vaginal infection. If you do delivery this way, you are able to avert perineal tear, whether first degree, second degree, third degree, or fourth degree. If you check patient's DP this way, you are able to facilitate the observation of a possible or a detection of a possible eclampsia or pre-eclampsia. I mean, we move away from identifying gaps and deficiencies to amplifying what works as far as our setting is concerned. And these are 10 things that fabulous leaders do. And one of them is that they introduce themselves. Hello, my name is Dr. So and so. The patient you have been seeing for the past X number of years, they don't know your name. I mean, your name tags are there, but they don't know who you are. Fabulous leaders introduce themselves. Fabulous leaders talk less and they listen more. And in listening, they listen empathetically. Fabulous leaders empower. They help others to develop also as leaders. And they encourage learning from their mistakes. I mean, in some of our settings, they say, hey, we will see if I am not there, we will see whether the work can go on. I mean, the African leader and the African concept of leadership is very warped. And we feel that, I mean, the leader should be the leader and should always be present, and everybody else should subordinate. But fabulous leaders empower everybody, they empower their subordinates or their followers. And if you have a fabulous leader, everybody is a leader. Fabulous leaders live the values, and they have core values that they live by. It's not that let's all come to work at 8 o'clock and the fabulous leader is coming at 10 o'clock and you know where I stay. No, they live the values. We are not extorting monies from patients, and fabulous leaders live the values. It's not that I am the so and so in the department, so as for me, I can collect. Fabulous leaders are accessible. When you need them, you can find them. They give credit and they are able to say thank you. Some of you, we have never said thank you before. We have even not said I am sorry before. And fabulous leaders remain positive. They welcome challenge. They recognize that they don't have it all, they don't know it all, and they have the humility to seek different views. Fabulous leaders are balanced. They know when to intervene and when to get out of the way. And it is only humility that can enable us do some of these things. And fabulous leaders also learn and develop. And the other is that as leaders, we should be able to create tomorrow today. And there are 7 simple rules that we can imbibe. One of them is that we should define our shared purpose. I have talked about it, how we can get everybody on board. And Peter Senge calls it our shared vision. We should define what we want our collective vision to look like. And we should root our transformation efforts in a sense of belonging so that everybody will feel that, hey, this is a team that I have to belong to. We should go backwards in the care or healthcare process as a core principle. We should be able to work upstream. We should be able to audit our process and see what works and what we can improve. We should be able to support people to build their power or their agency at every level of the system, especially when these people are part of our team. We should be able to understand that imbalances in power and privilege means that our team members have different starting points. So as far as the equity principle is concerned, we have to ensure some level of fairness and justice. And I mean, another thing is that we should be able to embrace contradictions and tension. I mean, in teams, conflict is inevitable, but our ability to embrace it, our ability to sort it out when it crops up is what makes us a team. And we should, I mean, leadership is about learning. Creating tomorrow today is about learning. So we should unleash learning as a power of transformation. We don't know it all. So we should continuously learn and learn every day. And it doesn't matter where we are learning from, whether you are the head or you are the tail. If you are the head, you should be able to learn from the tail. We should be able to humble ourselves and learn from the tail and learn anywhere that we can learn and acquire some level of wisdom. And we are action oriented. Action So there is small scale changes within a large scale framework. I mean, leadership and this creating tomorrow today is like one typical example I use is like chewing an elephant. If you are chewing, and it is not the kukrudu elephant, if you are chewing an elephant, I mean, you chew it little by little. You don't take the elephant as a whole piece and try to chew. That one, you are going to choke yourself to death. So you start small, but we are mindful that we are working within a large scale environment, and it will only be a matter of time that we are able to finish the consumption of the elephant. So leaders don't complain, they take action and initiative. And this is Atul Gawand. Atul Gawand is a doctor. He says that we shouldn't complain. And if you come across your colleagues who are complaining about how bad something is, we don't have to join in the chorus of complaints, because after you are done complaining, nothing has gotten any better, and you will only be winding up feeling even worse. So instead of complaining, let us take initiative. Let us appreciate, yes, there is a problem, but let us ask, what can we do to address it? Let us investigate. Why? Why is this thing happening? How many? Etc. Let us make connections. I have showed us the strong ties and the weak ties. As in the hospital department, let us ask and make the necessary connections. Let us identify solutions. Are there facilities where this problem never existed? Who has solved this problem before? I mean, Dr. Coleman told you about KBTH's starting of the obstetric triaging. We went to copy at Rage Hospital. So you identify solution. Who has done it before? Who has solved this problem before? And then you go and learn. Let us also take action. Let us do something. Let us do something before we die. Let us do something before we go on retirement. Let us do something before we leave our places of work. Instead of complaining, let us work with people of different backgrounds and beliefs. Let us organize a team. And there is a difference between a team and a group. The two are not the same. I mean, oftentimes we call ourselves A team, B teams. But you are more groups than teams. And let us deal with conflict among our colleagues, and let us influence and persuade. I have talked about influencing. Let us also design and improve the processes and spread the processes of improvement. A few thoughts on why leaders fail. Oftentimes, we try to do it all by ourselves, and we forget that the real issue is our ability to unleash the power of our team. Oftentimes, we get stuck in work as usual, and we forget that the old mindsets and the old models do not work. And we keep a tight control. We don't want to share. We don't want to open up. If you are like that, you are going to die and the work will still be there. So let us open up. Let us bring people on board. Let us create a team and unleash the power of our team. I mean, leadership can be as exciting and as interesting as this, that you don't even know who the leader is. You don't even know which direction these ducks are flying towards. Because at any particular point in time, leadership can change, leadership can flip and flop, because it is about our strengths and it is about our abilities. And whoever we feel and see is at the helm can come back, because when the storms are heavy and they don't have the tenacity and the wherewithal to withstand it, they will appreciate that the bird behind me is probably stronger and weightier than me, and that he or she would withdraw and leave the space for whoever have to fill in the space to come and fill in the space. So leadership can be as seamless and as nice as we are seeing amongst the dark. And that is what we should be practicing. I mean, Charles Darwin has said again, the species that will survive the future are not the most intelligent nor the strongest, but those who are capable of adapting to change. So we will have to change. Don't come and tell us that, as for me, that is how I am. As for me, that is how God created me. And there is nothing more difficult, Machiavelli again, to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. For the reformer has many enemies in all those who profit by the old order, and only lukewarm defenders in all those who profit by the new. So I end. Leadership affects the quality of patient care and safety, and the personality and behavior of leaders contributes enormously towards quality through the effect they have on well-being. And leaders in healthcare, such as you and I, should be mindful of the complex and idiosyncratic factors that are involved in the provision of high-quality healthcare. So I end. I mean, this is a personal plan that we always share whenever we do presentations like this. So you can take screenshots of it. Um, any three things you think you will have to be doing to improve your capacity to lead and manage quality in your department or your facility. And then three things you think you will need to secure the support of your colleagues. And three things you think you will need to secure the buy-in from your management team. Thank you. Any questions, comments, contributions? I am happy to take them.
Okay, thank you very, very much, Elom. Thank you so much for at least opening up a lot of things for all of us to appreciate. I think we have about 10 minutes for questions. So if anybody has a question or any contribution. But before anybody comes, I think you said quite some deep and important things that we all have to at least keep in mind, because as you said, leaders don't complain, and once we are trying to set up this this whole KY component to help with our healthcare management at 37, I think it behoves on us that at least everybody should have a part to play. It shouldn't be left to just a few number of people, because as you rightly said from the quote from Machiavelli, if you are trying to change things, it's quite difficult. Sometimes you meet a lot of resistance. But at least we are grateful that we've been able to come together to try to make a change in the hospital, so that we change the old approach of doing things, and then embrace the new ways of doing things. So thank you so much. I think I'll leave the floor to other people to also ask questions. Or if you have any question, if you want to type the question, you can type it and then I'll let him know. Can you all hear me?
Yes.
Okay, so any